Great. Yeah, thank you for the invitation to talk today. I appreciate the opportunity. I'm a rheumatologist practicing at KU. As a many of you may have a rheumatologist on your care team. We treat autoimmune diseases of all types in addition to arthritis. So we really take a comprehensive approach to myositis, and I'll try to make the case that myositis in our clinic is rarely just myositis. There's many other components to the disease to assess, and many other aspects that we really need to be looked into. So this is a very broad topic. We could go on probably for days and weeks, truthfully. I'll try to cover it kind of in some general detail and a few points I'd like everyone to know, and then I'm happy to take questions because the breadth here truly is wide. A couple of just things I'd like to cover is sort of the disease patterns and how autoantibodies frame our thinking about that. And then some specific conditions I'll discuss are Raynaud's phenomenon, arthritis, some of the skin and GI manifestations, and then briefly some treatment-related concerns to take into consideration. So as I said, myositis in my clinic is rarely myositis. Rheumatologists have a broad view of all organ systems. We need to for the complexity of the disease we see. So myositis may be one manifestation of a much more systemic disease. And to that point, our approach involves a very extensive pre-treatment assessment. So we really do, in anyone who comes in with one symptom, finding, or problem, there may be many organs involved, even if it's not clinically apparent at the time. So defining the extent of a patient's disease is the utmost important. Is there skin disease? Is there lung disease that's recognized or not? Is there blood vessel disease, for example? And then identifying treatment priorities is also important within that mindset. Someone's skin rash, of course, may be the most pressing problem, but if they have lung disease in addition to that, then treatment considerations need to take that complexity into account. And then addressing comorbidities is vital. So if someone has diabetes or liver disease, for example, that may dictate what treatments we choose to prioritize or potentially to avoid. And then, as many patients with this will know, long-term follow-up is necessary. Things change. Priorities change. So one organ system may be getting better while another organ system is getting worse. So really, you can't ever take your eye off the ball of what you're monitoring. And then, of course, the medications necessary to treat these conditions have their own potential side effects and toxicities. So it's a very important part of following this condition. So a lot of what we see is connective tissue disease. And just as a concept, it's important to understand that some patients will actually have a disease type that is characterized by overlapping features. A very commonly discussed condition is the mixed connective tissue disease. And this is a disease where, by definition, you have a combination of problems like lupus, rheumatoid arthritis, myositis, or systemic sclerosis. These patients will have the U1 RNP antibody frequently. Not all patients with this antibody have this disease type, but that potential always exists with that antibody. Another is the anti-PMSCL antibody, seen characteristically in people that have disease in multiple different organ systems. Now, another condition that we see is that people are actually predisposed to multiple autoimmune diseases. So conversely, there may be someone that does have myositis and rheumatoid arthritis almost as separate components in the same person. So if it just looks like myositis and an antibody is there just for myositis, there still may be more disease complexity. Similarly, scleroderma, which is my particular area of expertise and interest, scleroderma loves to overlap with many other diseases. So people may have liver disease, muscle disease, and scleroderma, for example. So understanding someone's disease phenotype is really vital to assessing risk and identifying what are the prognostic factors of importance to that person. What are we following? What are we tracking? How are we doing? The anti-synthetase syndrome, which I know has been covered in additional detail today, is one particular example of the overlapping potential for these conditions. This specific anti-synthetase syndrome, people will have one of the aminoacyl tRNA synthetase antibodies, which are listed on the right here, and then one or more of the components listed: the Raynaud's phenomenon, interstitial lung disease, inflammatory arthritis, which is typically an RA-like non-erosive arthritis, myositis, and then fever and/or mechanics hands. An important concept with the anti-synthetase syndrome is that oftentimes screening for systemic disease in myositis involves the ANA blood testing many of you may have heard about or are familiar with. And the anti-synthetase antibodies are non-nuclear, meaning that the screening test ANA oftentimes results in a negative value. And understanding that these antibody targets are actually non-nuclear. So we expect that negative result in this setting. So you have to actually think much more broadly in terms of how you will get lab work in this setting. This is a very busy slide that involves many of the antibodies seen in systemic autoimmune diseases, and highlighted sort of in the middle are the antibodies seen with overlapping diseases. So if you focus initially on the lower left part of this, these are our myositis antibodies. You see the anti-synthetase antibodies in this circle, some of the necrotizing myopathy antibodies and the dermatomyositis antibodies. And many of these antibodies exist within their own components, but myositis patients may have the PMSCL, the SSA, or the RNP antibody, which can overlap with these other diseases. So especially when we see some of these antibodies in the center, or a patient with these antibodies, I should say, we need to think more broadly about what may be going on. Furthermore, as mentioned, some people will have evidence, for example, of systemic sclerosis with a centromere antibody, but also have a JO1 antibody and myositis. So even if you think it may be a singular component, you still need to understand that some people will buck that trend and have additional components to their disease. So that's kind of the overlook of how we conceptualize and think about myositis, is understanding the degree of complexity that there's the potential for and making sure we look for that. I'm going to move to Raynaud's phenomenon. Raynaud's frequently occurs in myositis patients. In scleroderma patients, virtually everybody suffers from Raynaud's phenomenon. This is a condition where you have vasoconstriction, artery constriction, which occurs at the level of the digital arteries, precapillary arterioles, or cutaneous AV shunts. And characteristically, people with this condition are sensitive to cold temperatures. And then in cold temperatures, will have rather sudden changes from normal color to white, blue, and then frequently to red after 5, 10, 20 minutes when the blood rushes back in. So here are some characteristic photographs of Raynaud's phenomenon. You'll see that there's oftentimes a clearly demarcated zone between the normal skin color and where you've essentially temporarily lost blood flow. Some of the features of the Raynaud's in terms of what fingers are involved at different times and the involvement even within them helps us understand the risk for someone who has primary or non-complicated Raynaud's, or someone that has Raynaud's that's associated with a disease such as myositis. In its most extreme forms, Raynaud's phenomenon will threaten blood flow to the skin so intensely that the integrity of the skin is compromised and you can get digital ulcers. This should not be occurring in anyone with regular or primary Raynaud's. So this is a finding that when we see it, absolutely signifies the need for workup and treatment for the Raynaud's phenomenon. This is a photograph of an angiogram, which kind of emphasizes this. This is where they put dye into your arteries, and then they take a picture with an X-ray, essentially. So this is a healthy volunteer here who has their arteries in their fingers very strongly lit up, and you can see the robust blood flow and then how it kind of gets divided up in the tip of the finger. This is a patient that has Raynaud's phenomenon, and you can see how where these arteries are spasming, there's just no blood flow getting through, and then very little blood getting to the tips of the fingers. An important understanding of Raynaud's involves understanding that the skin has a role for thermoregulation, for helping you control the temperature to your body. So it's actually normal that you can deliver additional blood to the skin. Think of getting flushed when you're overheated. And you can also restrict blood from the skin so that you can preserve that heat to keep your internal organs and your brain warm, which it needs. So the nutritional blood flow to the skin is a deeper, separate network of capillary vessels. So many people that have Raynaud's, they just have these AV shunts affected. It's typically people that have systemic sclerosis or, in some cases, myositis, where that nutritional flow is jeopardized. So it's very important to kind of understand an individual's risk if they have Raynaud's phenomenon. Obviously, to manage Raynaud, staying warm is the most important part of that. Any temperature transition or situation where there's a temperature differential can be a problem. So a lot of people struggle more in the summertime, actually. If it's 100 degrees outside and 80 degrees inside, that temperature differential is what your body recognizes, and it may stimulate a Raynaud's flare. So there's an amazing amount of warming products out there, heated gloves, heated socks, heated muffs, heated mouse pads and keyboards for people that work at the computer. So for people that do struggle with Raynaud's, there's really nothing better than looking for these different products and finding ways to utilize them. Triggers are common for Raynaud's phenomenon: caffeine, stimulant medications, especially some of the ADD or ADHD medications, and then over-the-counter decongestants. I always warn my patients that if it has the D in it, the product has a D, or it's sold behind the counter, that's got the Sudafed in it, then it is a medicine that can constrict blood vessels strongly. Occasionally, we will prescribe vasodilators. These are commonly used high blood pressure medicines to treat Raynaud's. Some people also may need medicines that help to stabilize blood vessels, such as aspirin or statins, to help protect them. Statins, of course, have the potential to complicate myositis, so we use them judiciously. In severe cases, hospitalization may be necessary, and surgical options exist for resistant or severe cases of Raynaud's. Moving on to arthritis. Arthritis is a commonality to many people as we age, of course, but certainly anyone with an autoimmune disease has a higher risk of it. The arthritis we're principally worried about in the setting of myositis is an inflammatory arthritis. Inflammatory arthritis is characterized by swelling of the joints, redness, warmth, and then prolonged morning stiffness. So if the joints, especially the hands and the feet, are very stiff when you first wake up in the morning, it takes 30, 60, 120 minutes to really get them loosened up and moving. That's a signal that there may be inflammation components. And it's important because if there's inflammation over time, you get damage. So we do treat this condition similar to someone that has rheumatoid arthritis, for example. Some of the medications employed are hydroxychloroquine, methotrexate, azathioprine, and rituximab. So many medicines that overlap in terms of their use for myositis. But in someone whose myositis may be doing well, this may be a different priority. Skin and soft tissue manifestations are, again, a very broad topic. Many people will have dry skin, so it's really important to moisturize well and have a good routine skincare regimen. Skin rash is common. Itchy skin may be a component of the rash or the dry skin, but itchy skin sometimes actually signifies a different process. Calcinosis occurs sometimes early, sometimes late with myositis. Many overlapping patients, especially scleroderma patients, will have significant calcinosis. These are signified by little like rock-like densities under the skin, frequently in the hands and on the forearms, but truly they can be anywhere. And then lastly, wounds are very important for anyone with myositis. We've seen people, particularly in the hospital, where at the onset of their disease, they may be weak and not getting out of bed. So bed sores and wounds can result from an inability to be mobile as it relates to the myositis. So wounds are very important to require prompt attention if they're from pressure or from any other potential cause. With immune system abnormalities, wounds become more complicated and difficult to treat. Some photos that I know there was a session on DM already, but I'll just to highlight some of the skin rash patterns that we can see and some other findings with dermatomyositis. These are the very characteristic Gottron's papules occurring over the IP joints, and then periungual erythema, another common finding, essentially due to blood vessel dilation and blood vessel inflammation at those places. Nailful capillary changes can be seen right at the nail bed. We've actually seen people who noticed this themselves, and that was their first clue to the presence of a disease that was actually affecting many different organs. The heliotrope rash occurs around the eyes with a lot of associated edema. Gottron's rash here on the elbow. Again, emphasizing the amount of swelling that can occur around the eyes, and then rash on the face. Dermatomyositis likes to cause inflammation in skin that has received sunlight throughout your life. So it's not necessarily just the case that sunlight makes the rash worse, but areas of skin that have received sun in the past tend to be involved. So that's the reason for the characteristic V sign and the shawl sign that we see on the upper back. Calcinosis can easily be detected on a plain X-ray. I frequently get the question of, how do I know if I have calcinosis? And it's actually rather straightforward. There is so a plain X-ray shows calcium beneath the skin very easily and very nicely in most cases. And again, it tends to occur here on the forearms. Sometimes it could occur on the lower legs also. We see it around the knees at times. Moving on to gastrointestinal manifestations. Again, this could be an entire lecture by itself. I kind of just included this graphic of the intestinal system because truly anywhere from the top to the bottom can be involved to some degree with myositis. So dry mouth and facial and dental changes are very common. The muscles involved in mastication can be involved, making eating and chewing challenging. Dysphagia from the esophagus or the pharynx not functioning well can make eating more challenging and can contribute to aspiration pneumonia. Acid reflux occurs due to involvement of the muscles at the lower end of the esophagus. If that lower end of the esophagus is supposed to be tight to keep contents in the stomach, but if that esophageal sphincter is open wide, then things from the stomach can come right up into the esophagus. And this is a frequent problem in people with myositis or overlap connective tissue disease. The same muscles that control swallowing control movement throughout the intestines. So sometimes the food just doesn't move through the intestines well, and this can contribute to a host of problems: constipation, poor absorption, or bacterial overgrowth. A topic frequently observed, but not as much discussed, is anorectal dysfunction. So the muscles around the anus, the anal sphincter, could be compromised, leading to stool incontinence. This is and pelvic floor instability may sort of compound that as well. So this is something that, especially even later in the disease process, many people are affected by. Unfortunately, I believe it goes undiscussed and perhaps unaddressed, but there are therapy modalities that can help with this. So pelvic floor therapy and biofeedback are some ways that this can be addressed, even if pharmacologic therapy has a way to go in this realm. And then lastly, liver involvement can be seen also. It's a lesser seen complication, but it's also not sought for quite as often as it should be. And then I want to end kind of just discussing some treatment-related concerns. An unfortunate part of treatment for many with myositis are corticosteroids, which work very, very well to control inflammation, but they have side effects. It was actually a major topic of discussion at our Rheumatology National Meeting this November, looking into the length of time steroid side effects take to resolve. And there was very interesting research showing that for 2 and 3 years after you've completed a course of steroids, there are some effects on infection risk and bone density. So I think we're still learning that those risks truly are long-lasting, longer than we think, both the metabolic side effects of weight gain and the diet change, the bone mineral density effects, and then the psychiatric components, which especially with the high doses of steroids. And then infection risk, of course, is so important with the steroids as well as the other immunosuppressant agents that may be used. I'll just end mentioning multidisciplinary care. As a rheumatologist, we think broadly. We need help from other people. So we treat this disease by collaborating with experts like Dr. Dimajki, like Dr. Mark Hamblin, both of whom I know well. And so understanding how different components of your care team may be important for different components of your disease is really vital, and having the ability for them to work together also is the important part to treat the myriad potential complications. So thank you. I'll take any questions if there are any.
Awesome. Thank you, Dr. Schmidt. That was a great presentation. I am going to combine a couple of questions from the chat that have to do with like liver disease with myositis. One was just wondering if you could elaborate more on that, and this other one is a bit more specific, where they have ANA PL12 row 52 and were diagnosed with CAD-M. They frequently have elevated ALT and GGT, and their liver biopsy showed nodular regenerative hyperplasia and shunt-shaped vessels, and they have high pressure gradient per liver wedge. And they want to know if you see this with myositis and if this could be caused by an overlap condition.
Yeah, this is a tough and very specific question. So I'm not sure how specific I can get into. I would say if you've reached the point of having a liver biopsy performed, you're likely under the care of a hepatologist and a care team that at least knows what they're doing and is looking for things. The focal nodular hyperplasia, I don't believe, is a myositis-related complication, so it may be that there's a different process at play. Presumably, autoimmune lung disease is sort of the condition that we worry about as an overlapping feature. And if the biopsy doesn't show that, then it may be that there's another process at play. I think, does that answer the question?
Yeah. And then I guess, do you also just see liver disease or liver
Yeah, I guess one of the ways. So the liver blood test. This is sort of a problem in medical nomenclature. Liver blood tests are also blood tests that come from muscle. So it's quite common that a patient that has myositis, certainly early in the course, will have elevated liver blood tests. And we see people going to get biopsies of their liver when the disease is in the muscle too often. So typically in those cases, the liver is not truly affected. But I mostly wanted to emphasize the point that particularly primary biliary cholangitis occurs with overlapping syndrome. This is oftentimes in these patients, the alkaline phosphatase may be high, itchy skin may be present, and a biopsy or really the autoimmune markers for liver disease can usually identify this condition. A straightforward myositis typically does not involve the liver, though. So if someone was diagnosed, for example, with polymyositis and has normal liver tests, it's probably not affecting the liver unless there's something specific going on.
Thank you. Jane, I'll let you answer or ask your question since you have your hand up.
Thank you. Can you have Raynaud's in your feet and not your hands?
Absolutely. Raynaud's can affect many parts of the body. So the hands and feet are most commonly involved. We see it in the nose, in the ears, and the nipples. So many different places that get that exposure to cold temperature can have it. Other processes can affect the feet also. So many people have sort of venous dilation and blood pooling in the legs. And in these instances, the legs or the toes will sort of stay purple as opposed to turning white. And the difference there has to do with venous dilation and blood pooling causing this acrocyanosis. Raynaud's phenomenon is signified by the arterial vasospasm. So a sudden onset of blood loss and white color change is what we expect with the Raynaud's phenomenon. People may have both, though. So it may be that the same person has different components at different times. But yes, it can be in the toes, not in the hands. It can be in other parts of the body also.
Thank you.
All right, and then I'm going to combine a couple. So one question is, can muscle weakness come and go like a flare-up? And can hydrochloroquine and azathioprine cause diverticulitis flares?
So muscle weakness can come and go and flare. It can do that. I don't think of it as doing so quickly. So myositis shouldn't flare in a day or two and be better for a couple of days. It certainly would go more on the weeks to months, even years type of category. So people who are having more myositis activity may get worse over the course of many days or weeks. And sort of experience a flare that's longer lasting. But so yes, that's possible. Can treatments like hydroxychloroquine and azathioprine cause diverticulitis flares to become worse and more frequent? It's a good question. Generally, we don't regard hydroxychloroquine as an immune weakening drug. It's true that it works on the immune system, but we don't consider it an immunosuppressant. So I wouldn't think that's likely. I also believe what I was taught, that any drug can cause any side effect at any time. So for an individual, it may be possible, but it's generally not thought to. Azathioprine, being an immune weakening drug, could contribute to more episodes or more severe episodes of diverticulitis, although it's not a common effect that I have experience with.
Okay, and then maybe go over your like which medication is your first, third, second line of defense. It looks like there's like a question about methotrexate and
Yeah, you might see
mycophenolate.
that. It's a great question, and it should be highly individualized. As I was indicating earlier, patient's disease complexity may dictate what we are going with first, second, or third. It's generally regarded that methotrexate and azathioprine are your first go-to options strictly for myositis, if there aren't other organs involved. Many people think that the mycophenolate maybe maybe belongs up there in that group. I personally don't feel it does, unless you're seeing lung disease, where actually mycophenolate is our preferred drug. So we have good data, especially in scleroderma, from the scleroderma lung study 2, showing that mycophenolate was as effective as a prior medicine we used called cyclophosphamide. So mycophenolate may be better if you have multiple organs, including the lungs. I always am very clear that the medicine that works for a certain individual, the better medicine is the one that works. And we oftentimes don't know that until we have found that medicine A doesn't work or isn't tolerated, and medicine B did a great job. So I see a comment about Imuran. Imuran and azathioprine would be synonymous. And I think azathioprine is also a good medicine that has a broad range of impact. For example, can help multiple organs. Another component about mycophenolate is it tends not to be a very good arthritis drug. So if arthritis is a big component of a patient's disease, we may favor methotrexate or azathioprine over mycophenolate for those reasons. This is more for initial therapy. As we get into later lines of therapy, we may be using combinations, for example, with hydroxychloroquine, rituximab, and even newer therapies.
In cooperation with their care team, can people with antisynthetase syndrome have like a slow progress with disease without steroids to avoid all those side effects?
Let's see if I understand this correctly. There can absolutely be a slow course to this disease. It doesn't always go quickly. Someone may have lung disease, for example, that progresses very gradually over 10 years, even imperceptible to an individual. We want to know about that and track it. Is treatment necessary? That's a highly individualized part of understanding someone's risk. So yes, there can be sort of a very slowly progressive phenotype. And given other factors, certainly someone's age is going to be a big part of how aggressively they may want to be treated. Looks like questions are rolling in. Are you taking new patients? Do you see veterans? I do take new patients, but I work at KU, so we rarely see veterans there. IBM, I see a couple comments about IBM. I appreciate those. Rheumatologists tend not to be as involved with the care of IBM, with it being a bit more of a myositis muscle-specific condition. So generally, IBM is managed, in my understanding, by the neuromuscular neurology team. We will get involved if necessary, certainly if there are other disease components. But I like this comment about IBM and gout, because this is a really important topic, is that you're allowed to have many different problems. So if someone with myositis also has gout, that needs to be separately managed because it has major impacts on other organ systems. I see a question. Yes, please.
Any comments on CAR T-cell therapy and IBM?
Great question. We are So CAR T cell therapy is an emerging topic. For those of you that aren't familiar with it, this is this is a treatment that's being done now for leukemia and lymphoma, where someone's own immune system cells, their T cells, are taken out of their body, re-engineered to kill other immune system cells, and then delivered back. So it's a very, very strong treatment to target a part of the immune system. And there was groundbreaking research presented about 2 years ago in lupus patients, where a small group of lupus patients entered a prolonged drug-free remission after this CAR T cell therapy. So there's an enormous amount of interest in this as a potential to shut down the disease. So some myositis patients and scleroderma patients have also been presented. I'm not aware of an IBM patient having been treated or presented yet. If it's possible that they have been, but it's a very active and new field. So I don't know if IBM is going to be studied for CAR T cell therapy. I think it'll be likely, but I'm not familiar with that yet.
Yeah, we're hopeful, but nothing quite yet has popped up.
Yeah, certainly for the antisynthetase syndrome, DM, PM, necrotizing myopathy, overlap syndromes, CAR T is getting studied for that. We actually have CAR T trials at KU that are just opening for lupus nephritis, and systemic sclerosis that we're just about to get started with. Let's see. I see a comment. I might be skipping over. If someone went from a diagnosis of UCTD in 2010 to DM in 2023, how would you approach cancer screening and organ monitoring? Cancer risk is cancer from the disease or as a perineoplastic syndrome is most likely to be seen early in that course, first 3 to 5 years. So I think the antibody type that someone has probably would be a very important part of assessment for how high cancer risk is. Certain antibodies, the TIF1 gamma, for example, has a much higher risk of cancer association than the antisynthetase antibodies. JO1, for example, they have negative cancer associations. So I think the antibody type would be important in terms of how aggressively you screen for cancer. But I think given the length of time that went by as the disease evolved over 13 years, the cancer risk would probably be low, but it's a good question to review with your care provider. Synergistic effects are believed with Imuran and Rinvoq. Yeah, I don't have good insight into the use of Rinvoq yet for myositis. I don't have experience doing it. I do believe it will be a future option. And there may be increased cancer risk probably with more aggressive immunosuppression, but I don't have any specific info otherwise regarding that question.
And then for patients who have a normal CK and are clinically stable, but still have muscle aches that are constant, what do you recommend for them to talk with their doctor about?
Yeah, so muscle pain apart from apparent active inflammation. Yeah, that's tough, and that may need to be individualized. So pain management, certainly exercise as able is important. I believe CoQ10 is sometimes recommended, but I'm not aware of any other particular medications to treat that apart from pain medicine or pain management in general. Do
you have a medication that you recommend for inflammation and pain to your patients?
It's highly individualized, I think. Certainly NSAIDs like Advil or Aleve have a role, but they have their own potential side effects, so they need to be prescribed cautiously. If there's a nerve pain component, medicines like gabapentin or pregabalin may be an option. I tend to sway away from pharmacologic pain management. I have feelings that oftentimes pain management endeavors can skew or cover up disease. So I'm also a strong believer in judicious use of medications in general. So I really try to focus on non-pharmacologic measures, be that exercise, topical therapies, those types of things. I feel that those are far more important than a medication to manage pain. Just so that other things may not be overlooked, and we keep our priorities straight, and trying to push function along with pain management, I think is more important. I see a question about having MDA5 positive blood. Does that always confirm definitive diagnosis? That's a good question, and I think it introduces a broader topic about the blood test and the disease, and they truly are different things. So what we do as rheumatologists, frequently examining and getting referrals for patients that have abnormal blood tests, which might be obtained for any number of reasons. So it is vital that we focus on what a patient is having going on with them. And we will see many people that have antibodies that don't have disease. And so no, having a blood test abnormal does not make a disease. It is also true that some people will have abnormal blood tests before they have the disease. So you do need to assess deeply in someone that has an antibody, assess them for a disease, and you may need to then risk stratify and come up with some type of plan to monitor for the evolution of their condition into a disease. But just because you have a blood test does not provide a diagnosis. I mean, MDA5 we know is an important antibody that has a higher risk of bad lung disease. I do have patients I've seen with that antibody, even that have other diseases and have not developed interstitial lung disease. So the antibody doesn't make the disease. It can be helpful, and it can help us alert ourselves to priorities, but it doesn't make a diagnosis. Have you ever used leflunomide to treat DM? No, I have not. And that doesn't mean that there's not a place for it, but I haven't done it.
Okay. Are there any other questions for Dr. Schmidt?
I appreciate it.
Thank you so much. We appreciate you joining and giving your presentation.
Thank you.
Okay, cool. Sounds good. All right. Hello, everyone. So this is a little bit bigger group than we had just a few minutes ago. And so just